the daughter of a general internist, and my mom was actually a respiratory therapist before she became a stay-at-home mom with me and my brothers. So I've grown up around medicine all my life, and ultimately decided I needed to utilize what I was being taught in the classroom in college and how to apply that to real-world things, real-world situations. I couldn't do this job where I sat behind a lab bench all day. I needed to talk to people. I needed to help problem solve, and medicine provided that for me, provided that challenge, and provided that service opportunity as well. I see patients with asthma, COPD, chronic respiratory failure. I see some basic sleep apnea patients as well, and help with CPAP equipment, BiPAP equipment. I also I see patients with blood clots, pulmonary embolism, DVTs, as well as patients with interstitial lung disease as well. The vast majority of pulmonary issues can be seen here and seen in a regular pulmonologist's office. I'm not saying I'm just regular, but somebody within the local community. You don't have to go across the river. You don't have to drive up to New York or the NIH to get what you need. There's amazing people in the area. You just have to know and ask. What has been a big game changer in the asthma world over the last 15 years or so, it has been the biologic movement. We see that a lot advertised for things like psoriatic arthritis and Crohn's disease on television, starting to see advertisements for allergic asthma as well. And for the right patient, it really has been a game changer. There are some COPD patients that actually fall into this category, and I really am a big proponent of identifying those patients and trying to make a plan of, if this inhaler doesn't work or this modification doesn't work, then we need to consider some of these other more advanced meds. And I explain to patients in the office as to why that's important and how we go through that. The other thing that's really changed treatment in my line of work is lung cancer screening. I am a very big proponent of lung cancer screening. In this past year, they reduced the age and PAC year history. So patients who were still at risk that we couldn't get approved by insurance now can fall into that category. So the age of 50 years old and a 20 PAC year smoking history with some other details thrown in there almost undoubtedly gets us approved for lung cancer screening CAT scan, which, if we can find something early and detect early, is much better than finding out much later, because oftentimes lung cancer is very silent. It's silent until it's not silent. And then we're kind of backtracking and trying to make things better when we could have tackled them from the get-go. I want patients to forget that they have an issue, whatever their problem is, whether it's asthma, COPD, sleep apnea. If I can make it feel like a part of your life and not that you're defined by your disease, then I've done my job. Allowing patients to be able to maybe make that graduation, even though it might be a little bit tough, of their grandkids, or run around on the soccer field when they didn't think that they could. Those are the things that motivate me to do what I do, but also hopefully, get us all to the same goal.